So without further ado, I want to introduce you to our speaker. And I apologize for looking away. I have his bio over here, obviously to my right. So I'm gonna read that. So today's speaker is Dr. Brent Boyette. Dr. Boyette received his doctorate in dental medicine from the University of Alabama at Birmingham and his osteopathic medical degree from the University of Health Sciences in Kansas City, Missouri. He completed his residency in family medicine through the University of Mississippi and currently holds a board certification in family medicine and 2 board certifications in addiction medicine. He has been recognized as a distinguished fellow by the American Society of Addiction Medicine. Dr. Boyette currently is working with Bradford Health Services and is dedicated to continued growth in the rapidly evolving medical environment of addiction medicine. His primary focus is on addiction treatment and research, and he remains on the cutting edge of technology and training. So please type any questions that you have for Dr. Boyette in that Q&A box. And Dr. Boyette, the mic is yours.
Thank you, Dr. Robertson. I appreciate it. Can you hear me okay? Is everybody okay? Excellent. Well, good afternoon and happy Friday to everybody. I wanted to make sure that we have our technology in place, and it seems like that we do. So let's just quickly run through the learning objectives that I'd like to cover with you this afternoon, and then we'll go through the process of the slides, and at the end we can actually answer some questions and have some discussion about this. So the learning objectives here are to examine the concept of opioid-induced hyperalgesia. We want to discuss the importance of pain and pleasure in the survival of any given organism. We want to summarize the concept of hedonic tone and how it relates to addiction and survival. We want to critique why Alabama leads the world in per capita use of prescription opioids. And finally, we'd like to evaluate and see if Alabama's chronic pain epidemic could be, at least in part, due to the treatment of pain itself, due to iatrogenic causes. So with that, let's go to the next slide. So this United States and people in America did not always use opioids the way that we do today. In fact, we didn't always think about pain the same way that we do today. It was not until the late 1980s when we experienced the dehospitalization movement that we begin to prescribe more and more outpatient opioids. In fact, prior to the 1980s, if you were sick enough to be on an opioid, in most cases, you were sick enough to be in the hospital. People would slip a disc, or they would strain their back or injure themselves in some way, and doctors in many cases would put them in the hospital for a week back in the 1970s and give them IV morphine and use these kinds of medications. But at some point during this time, the doctor would walk into the room and say, "It's time for your discharge." And so the patients would go home, but they would not go home in most cases with self-administered oxycodone and hydrocodone. See, during most of the 20th century, American doctors had remembered the lessons from the last great opioid epidemic, which was at the turn of the last century, 100 years ago. In the late 1800s and the early 1900s, doctors and their prescriptions and the use of opioids were highly unregulated. In fact, for a period of time, you could literally buy heroin from the Sears and Roebuck catalog without a prescription. It became such a tremendous problem by the late 1800s and in the turn of the new century, of the 20th century, that Congress took the unprecedented act of getting involved with the regulation and the use of medications. In fact, in the early 1900s, the Harrison's Anti-Narcotics Act was passed by federal legislators, placing great limits on the use of opioids and other addictive substances like cocaine. And during the early part of the 20th centuries, doctors were prosecuted, and so too were pharmacists, for their cavalier use of opioids during this time. And so one of the first cases that was ever tried, or was actually a landmark case in the United States, was a case that occurred in Memphis, Tennessee. I think it was around 1919. It was called Webb versus the United States of America. And the Department of Justice and the Internal Revenue Service actually brought charges against a pharmacist for the administration of morphine for the treatment of morphine dependence. Basically, the ruling in this landmark court case was that it was unlawful and it was a violation of the Harrison Anti-Narcotics Act for a healthcare provider to provide opioid maintenance to a person for the treatment of their opioid dependence. And that was the law of the land all the way up until the 1970s, when President Richard Nixon signed into law the Controlled Substance Act. And with that, there was a carve out of an exception to the Harrison's Anti-Narcotics Act, which was known as the methadone exemption. And methadone, through federally qualified and highly regulated opioid treatment programs, was created as an exception to opioid maintenance with an opioid. And that was the only option for opioid maintenance until 2000, when the Data 2000 Act created the second exemption from the Harrison's Anti-Narcotics Act, which was the use of buprenorphine for opioid maintenance. Beyond this, the law said that opioids must be used for pain, for the treatment of pain. And most of the time during the 20th century, that was for short-term isolated use, most commonly in the inpatient hospital setting. But as we entered into the 1990s, the dehospitalization movement became a movement. Outpatient home health care became a thing. Home hospice became a thing. And the increased administration of self-administered opioids became an increasingly common situation through the 1990s. In fact, it was such a paradigm shift in the 1990s that CMS and other government entities became involved in incentivizing the use of comfort pain medications. In fact, in the 1990s, healthcare providers, including Medicare and Medicaid services, said, we're not just going to provide for care, we're going to pay for quality care. So how do you measure quality? Well, one of the metrics of quality of good medicine were pain scores. If you remember, in the 1990s, pain became known as the fifth vital sign. And during this time, metrics of quality of care were placed in hospital settings and with doctors. So if a patient came into the hospital and Dr. A was able to get your pain from a 10 to a 2, and Dr. B was only able to get your pain from a 10 to a 5, Dr. A was graded as being the better doctor. He or she was entitled to sometimes greater financial reimbursements from the insurance providers, and so too were the hospitals. So there became a great drive during the 1990s to increase the use of comfort medications, including opioids and benzodiazepines. So if metric, or if the measure of a good doctor is who can relieve pain the best, then I can prescribe oxycodone and hydrocodone just as well as the next doctor. And throughout the 1990s, as we were incentivized to use more and more chemical comfort for our patients, we saw opioid prescribing go up each and every year through the late 1990s and through the turn of the century. Next slide, please. And then about 10 years following this, we begin to see the consequences of these policies. Many of you can remember in the 1990s when the pharmaceutical industry, as well as the government and other organizations like the Joint Commission on Hospital Accreditation, encouraged doctors and incentivized doctors to be more liberal with comfort medications. But by the turn of the century, we begin to see the situation where an increase in overdose deaths begin to increase. And unlike the heroin epidemic of the 1960s. We begin to, where most of the time heroin, in 80% of the cases, heroin was the first opioid of abuse in heroin addicted patients. In the new century, most heroin addicted patients actually begin using prescription opioids. And then as their tolerance and dependence increased, they turned to the street, the so-called pills to needles movement. So we begin to see drug overdose deaths around the turn of the century into the turn of the 2000s increase, going up each year. Next slide. Now, there's been several phases to the current opioid epidemic. The first was the prescription drug phase. As I said, according to the National Institute of Health, 80% of heroin addicted patients in 2011 actually started out using prescription opioids and then transitioned to street illicit opioids on the street. So what we began to see is an increase in overdose deaths involving prescription pain pills first. And then around 2013 to 2014, we begin to see the fentanyl revolution occur in the opioid epidemic. See, fentanyl is made in foreign labs by clandestine laboratories and is shipped to the cartels in Mexico and other smuggling areas. Now, currently, if you read the book Fentanyl Incorporated, it describes a situation where in many cases, Chinese labs will actually put together and assemble precursor kits to be cooked once they're shipped to a certain location. So in many cases, Chinese labs will assemble these kits and then ship them and sell them to other cartels who actually cook the fentanyl and ship it into the United States. And by the way, today's street fentanyl is not like pharmaceutical grade fentanyl. In fact, it's usually fentanyl analogs. And we see 1,4-dihydroxy fentanyl and carfentanil and other analogs with a whole variety of durations and half-lives and potencies. So it's really very much a buyer beware market. So around 2014, we begin to see the uptick in overdose deaths from synthetic fentanyl on the street. And now the most recent wave of the opioid epidemic is we're seeing combinations of drugs, combinations of fentanyl mixed with methamphetamine, combinations of hydrocodone mixed with Ritalin or Adderall. We're seeing combinations of oxycodone mixed with benzodiazepines or other pharmaceutical sedatives. So it's a combination. Next slide. So here's what we're seeing now. If you'll notice the dates, around 2015, we begin to see not only an increase of deaths, and these are post-mortem toxicology reports, not only are we beginning to see in 2015 opioid overdose deaths, but in many of those cases, increasing each year, we're seeing opioids combined with psychostimulants, such as methamphetamine or cocaine. Next slide. Or, as you see here, starting around 2004 and increasing pretty much on a steady incline since that time, has been the combination of opioids plus benzodiazepines. Next slide. So let's go back. How did we get here? And let's talk a little bit about this on a worldwide scale. So consider this. According to the World Health Organization report in 2011, the United States of America makes up only about 4.5% of the world's population. And yet, next slide. In 2011, the United States of America consumed over 80% of the global supply of prescription opioids. Next slide. In 2011, according to the WHO, we consumed 99% of the global supply of prescription hydrocodone, the active ingredient Lortab, Vicodin, and Norco. In fact, many of you can remember when hydrocodone was actually a Schedule III controlled substance. For whatever reason, back in the 1990s and the early 2000s, there was a sentiment that hydrocodone was somehow less addictive than oxycodone or other opioid derivatives, such as morphine and other derivatives. It turns out not to be the case. And now hydrocodone is a Schedule II, just like the other opioids are. Next slide. So, according to the Centers for Disease Control, in 2011, unlike previous opioid epidemics in the past, the most likely decade of life for a person to die was the 45 to 55-year-old age range, not the teenagers and the 20-somethings of the previous heroin epidemics. And interestingly enough, and perhaps even more shocking, for every age range, according to the CDC, in 2011, Americans were more likely to die from a prescription opioid overdose than they were from an illegal drug overdose. In 2011, American doctors killed more Americans than American drug dealers. Now, those statistics have since shifted and changed with the fentanyl revolution, but keep in mind that in many cases, it was our thought process about how we must eliminate all pain that began us on the track to this whole epidemic of moving from prescription opioids to synthetic fentanyl. Next slide. So in 2013, the Centers for Disease Control began to look at where these medications were going and why they were being used in such increased amounts in the United States. And what they found out was that there's not an equal distribution of prescription opioid use in the US. That when broken down by region, that the Appalachian region of the US consumed far more opioids than the East Coast, the Midwest, or the West Coast. And these are prescription opioids, keep in mind, not simply street opioids, but prescription opioids. In fact, the phrase has been coined the Appalachian Pillbilly region to describe our culture of sharing, selling, and trading prescription pills. Next slide. And in 2013, when the Centers for Disease Control broke down per capita opioid prescribing by healthcare providers, guess which state ranked number one in the entire United States? Alabama. Alabama prescribed in 2013 more opioids per capita than any other state in the United States, and Tennessee was a very close second. Next slide. So let's drill down on Alabama specifically. This is data according to the Alabama Prescription Drug Monitoring Program, and I've got to use my glasses and get close to read this. The peak of opioid prescribing in the US and also in Alabama occurred around 2015. Since then, we've been gradually dialing it back in our prescribing, and I think that's a good thing. But let's just look at the peak year, the year 2015, peak year in the US, peak year in the state of Alabama. In 2015, Alabama doctors prescribed almost 6 million opioid prescriptions. Next slide. In 2015, Alabama medical providers prescribed almost 400 million opioid tablets. Next slide. And in 2015, Alabama doctors prescribed over 5 billion with a B morphine milligram equivalents of prescription opium to our patients in the state of Alabama. An incredible amount of opioids were being distributed in our state. Next slide. So it begs the question, why do people in Alabama hurt so much? Why do we have such a chronic pain problem? Is there any evidence to believe that Alabamians should have more pain than people from China or people from India or from Europe? It also begs the question is, could the American chronic pain and anxiety, I could argue, epidemic be iatrogenic? In other words, caused by the way that we treat the actual symptoms. So the next closest contender to the United States was Canada. But as you can see in this graph, we almost double the opioid consumption of Canada that Canada prescribes in terms of prescription opioids. Next slide. So you hear this question all the time. In fact, doctors are always faced with this dilemma. Are they really in pain, or are they just addicted? You hear that all the time. We don't want to, people say we want to give them the benefit of the doubt, give them the benefit of the doubt. But here's the thing. When we ask the question, are they really in pain, or have they just gotten addicted? It makes me believe that the person really doesn't understand the definition and the concept of addiction. Because at the root of all addiction, there's pain. It could be physical pain, it could be emotional pain, but in most cases, it's a combination of the two. And opioids are quite effective at relieving those types of pain in the short term. But in the long term, there's strong evidence to believe that opioids used chronically over a period of time will both amplify and perpetuate the sensation of physical and emotional pain. Next slide. So, in order to understand addiction, we really have to understand the purpose of pain itself. We also need to talk about the purpose of pleasure, because these are important perceptions for our survival. See, in American culture, in modern Western civilization thinking, we have come to view all pain as bad. We have come to demonize pain. We have come to say that we need to eliminate all pain. To which I tell patients, the only pain-free state that you and I will ever achieve is death. You see, pain is essential to life. Pain is a defense mechanism. Pain in all its forms protects us from harm, and it helps us to survive. So think about this. Every motivation that we have every day of our lives comes back to the desire to avoid pain and to pursue pleasure. Everything, even all the way down to altruistic motives, come back to a selfish benefit in the end. We are herd animals. We survive better in groups. So empathy has a survival benefit for us as human beings. I care about you and you care about me. If I'm in need, you would come to my aid, and I have the urge to come to your aid in great need. It actually hurts us to see others suffer, and that is a survival benefit for us all. But everything that we do, all the way down to the most subconscious processes, occur because we want to avoid pain and pursue pleasure. So for instance, if I go too long without drinking fluids, water or any other kinds of fluids, my hedonic tone with dysphoria on one end and euphoria on the other end. And most of us live with a homeostatic balance. But if I go too long without taking in fluids, water or whatever, my needle will move toward a slight form of dysphoria called thirsty, and I'll be compelled to go get something to drink, which will restore my pain-pleasure balance and keep me from dying of dehydration. I don't have to set my alarm to make sure that I consume water or fluids every few hours. It's automatic. I feel dysphoric. I'm compelled to fix that dysphoria with fluids, and I don't die of dehydration and kidney damage. The same thing is true with nutrition. We are compelled to plan for our nutritional needs, and what makes us a society plant crops in the spring and tend them all summer to avoid the pain of famine in the winter. Everything that we do, sex, it all gives us pleasure, but the reason for pleasure in sex is because we're not going to get out of this alive. And in order for us to survive as a species, we have to be compelled during our reproductive years to procreate and to share our genome with future generations. So that becomes a very strong and pleasurable component or compulsion during our reproductive years. But it all comes back to survival. Everything that we do, every moment of our existence is motivated by our pursuit of pain and our avoidance of our avoidance of pain and pursuit of pleasure. The way that you sit in the chair, you've chosen this position because it's comfortable, but it's comfortable because it's functional. What I mean by that is this: if you were to examine your body, you would find that the lymphatics are unimpeded, that the capillaries are still delivering oxygenated hemoglobin to your cells. But if you sit on one butt cheek for too long and you compress those capillaries, so compress the lymphatics, then you will become slightly uncomfortable and you'll be compelled to shift your weight from one side to the other, and blood flow will be restored to the tissue of that side of your butt cheek, and you won't get a pressure sore. But doctors can put people in the ICU and provide such chemical comfort with fentanyl and propofol and other chemical comforts, and a person will lay on one spot and they will get skin breakdown. It's important to feel pain. We cough because there's something uncomfortable in our airway. And it's in our best interest to get that out, to expose that and to get it out of our bronchial tubes. One of the best cough medicines on the market is hydrocodone and codeine. It doesn't do anything to help our lungs. It just dumbs our brain up so that we can ignore the fact that there's a problem in our lungs. I ask the patients this. I say, let me ask you a silly hypothetical question. If I were to stick my hand in a fire and the fire began to burn the flesh off my hand, should I A, remove my hand from the fire, or B, just leave it in the fire, but take a pill so that I don't feel the consequences of my situation? A similar thing could be said about benzodiazepines. A woman comes to the doctor and says, I have a terrible marriage. My husband's abusive. I'm in a bad job. I have a terrible relationship with my spouse. And I'm behind on my car payment. And I took some of my friends' Xanaxes and it made the pain in my life go away. Can I get some Xanaxes for my nerves? So the doctor prescribes Xanaxes or Klonopins or whatever that emotional pain pill might be. And the person leaves their hand in the fire. 6 months later, she comes back in. The husband almost killed her. She was beat up to the point that she was put in the hospital for a week with a head injury and a chest tube. She's lost her job. The repo man has taken the car, and now they're about to be homeless because they're behind on their rent, and she's going to need an increased dose of Xanax because she's beginning to feel the pain of her life again. See, to take away the feeling of pain is a high duty for a doctor. If you're an anesthesiologist, you know what I'm talking about. Because when you take your patient to the operating room, you're taking away their self-defense mechanism by providing a general anesthesia. That patient can no longer control their airway. They can no longer protect their lungs, and they no longer have the desire or the drive to breathe in a deep sedated state. So the anesthesiologist has a duty to provide that protection for that patient who is anesthetized. You see, to take away pain from a patient is a serious responsibility, and we need to consider it that way. Pain is an important self-defense coping mechanism. Pain is what creates the incentive to fight for life. And I talk about addiction medicine, and some people say, well, what is an addictionologist? What is addictionology? And this is my Alabama kind of, I guess you would say, country boy explanation for addictionology. Addictionology is the field of medicine that helps patients establish and maintain a functional balance between pain and pleasure. You see, there's a sweet spot, homeostasis as we call it, in between dysphoria and euphoria, where we function best, where we are on our A games, so to speak. We cannot function at our best if we're in agony, but we can also not function at our best if we're in a euphoric state as well. It's in that hedonic tone sweet spot in the middle, homeostasis, just like everything else in nature, that we function and survive best. So pain is important, and we need to rethink the demonization of pain in the United States and in Western civilization. Next slide. But so too is pleasure. So too is pleasure, and pleasure is an important incentive for us to get up and do things to help perpetuate our survival and the survival of our entire species. So yes, food, water, sex, even repositioning ourselves. Last year, 2020, during the height of the pandemic, opioid overdose deaths reached a new record level. Estimates say that over 90,000 people in the United States died of an opioid overdose last year in the United States. What actually happened to those people? What caused their death? I'll tell you. They took an exogenous chemical that pushed their hedonic tone so far into a state of euphoric pleasure that they didn't feel the threats of anything. They didn't feel the threats of their stomach contents going down their airway. They didn't feel the threats of hypoxia. Any anesthesiologist or anesthesia provider will tell you that as you provide chemical comfort into an IV, very common the patient will relax their own vigilance. And if you overshoot the runway with your Versed, fentanyl, or other pleasure-producing substance, then the patient will lose their drive to even breathe. And you'll see the pulse oximetry go from 95 to 90, 85 to 80, 75 to 70. And if somebody doesn't step in and do a chin lift jaw thrust or a positive pressure ventilation or reverse the overdose with Narcan, then the patient will quietly and comfortably die of an overdose of pleasure. False pleasure is deadly. You can see this in the patient's will to survive on any given level. And we as healthcare providers have a high duty. If we take away that patient's God-given instinctual pain perception, that's a serious situation. People are increased risk for aspiration pneumonia, hypoxia, and all sorts of other things, including deep vein thrombosis due to inactivity and laying around too much venous stasis in our legs and pulmonary embolus. I could go on and on by the threats that overdosing pleasure can give to our patients. Next slide. So what does this actually come back to? And what's wrong with pleasure? I mean, yes, pleasure keeps us vigilant and keeps us on our A game, but what's wrong with just every night coming home to some Norco or to a bottle of vodka? Pleasure is not given to us. In fact, I tell patients, there is no such thing as a drug or a chemical that gives us pleasure. It only loans it to us, and it has to be paid back. And unfortunately, it has to be paid back in the form of pain. So Solomon and Corbett described this in 1974 as they described their opponent process theory of the brain. But if you go back in the German literature, opioid-induced hyperalgesia was described 100 years ago. We can find the literature talking about the fact that morphine over time actually increases the perception of pain. So too can be said of benzodiazepines in their increasing the perception of anxiety or insomnia. So how does this work? Solomon and Corbett said that any stimulus that alters brain function to affect the way that we feel will elicit a response by the brain that is exactly the opposite to the effect of the stimulus. When we experience perception or emotion, an opposing perception or emotion will counter the first, over time lessening the experience of the perception. And then there will be a rebound effect that will be the opposite of the experience of the drug or the stimulus that we see. This is the underlying root of tolerance, dependence, and addiction. It has to do with neuronal adaptation. The brain is not a static organ. The brain is constantly changing. The brain is constantly using itself to optimize executive function. So if we're trying to inhibit that executive function by alcohol, opioids, benzodiazepines, and other forms of false pleasure, the brain will actually rev itself up to oppose those. It has to do with neuronal adaptation and the ability to feel pain and pleasure based upon real world circumstances and not the chemical content of our blood is so important for the survival of the organism that the brain has built in backups and fail safes. Keep in mind, the brain is going to try to maintain homeostatic balance, even though we're trying to push it toward pleasure, pleasure, pleasure. This is the basis for the disease of addiction. Next slide. So Solomon and Corbett described it this way. And imagine the vertical axis that you're seeing on your screen here, with the top 100 being euphoria or a smiley face, and the bottom 100 being dysphoria or a frowny face. And then imagine that there's time across the horizontal axis, and that the graph represents the perception of pain and pleasure over time. So if I swallow a pain pill, immediately following that pain pill, I will experience a sense of pleasure. It will peak at A, and then it will drop down to adaptation to readjust. The brain will adjust to that, and then it will plateau, and then there will be a fall off in the pleasure as the duration of action of the opioid wears off. But it doesn't go back to the baseline. It actually falls back slightly to the dysphoric side, sort of the rebound effect, if you will. That would be the hangover after a drunk, or the crash after the methamphetamine binge. The stimulus, the response to the stimulus of the drug, we call, Solomon and Corbett called the A process. And the rebound effect, Solomon and Corbett called the B process. A process is the effect of the drug. B process is the rebound effect, the hangover, the crash, so to speak. So, I mean, it's not such a big deal if there's a one-time use, but assume, next slide, that we begin to do this on a frequent and regular basis. What's happening to our brains? As you can see in the top left-hand graph, the first A process is pretty high and the B process is fairly mild. But if we do this over and over and over again with repetitive use of alcohol, repetitive use of benzodiazepines, and repetitive use of opioids, then over time, the A process will become blunted and inhibited, but the B process will become more and more profound. This is where tolerance comes from. This is why a Norco 5 was fine to get you through the morning in the beginning, and now it takes a handful of Norco 10s just to get you started in the morning. It has to do with neuronal adaptation, that the brain is trying to oppose the pleasure perception of the substance to keep the patient vigilant and alert to optimize survival. So if we use this stimulus over and over again repetitively on its heels, we will develop a roller coaster ride effect. In fact, it is very common for doctors to misdiagnose patients with substance use disorders as having bipolar disorders. Now, let me be clear, the two can co-occur, and that does happen, but in many cases, when you stabilize hedonic tone by stabilizing the substance use disorder, you will find that the mood disorder will clear up itself. That the roller coaster effect of hedonic tone can create a behavioral or a mood disorder that will mimic a bipolar disorder. And that's why I encourage you, if you're a doctor or a provider that does treat bipolar, manic depressive type diseases, always randomly drug test that patient. Randomly drug test that patient to make sure that you're treating a true organic bipolar disorder and not one that's complicated by a substance use disorder. Not only is it a roller coaster ride, but the roller coaster ride does not correlate well with the circumstances that surround the patient. In other words, the patient feels fantastic, even though their life is falling apart, or their pain is excruciating, even though the doctor is struggling to find a cause for the pain. And over time, it's a roller coaster ride that goes downhill in the sense that the highs, in the sense that the highs are not as high as they used to be, but the lows become increasingly more and more painful, both physically and emotionally. Next slide. So here are some facts about addiction I want you to take home with you. Number one, addiction is a chronic disease, and I don't have time to get into all this, but it is not a curable disease. A person doesn't go to rehab and get cured of their addiction. They go to rehab and get their addiction controlled, driven into remission, if you will. But the patient needs to think of themselves as never being disease-free. You don't have to be sober for the rest of your life, but you have to be sober today. And tomorrow, you have to be sober today. That's the way you eat that elephant. Secondly, addiction is not substance specific. In other words, it's not opioids that they're addicted to. It's not alcohol. It's not benzodiazepines. It's not even nicotine. It's dopamine. And nicotine and opioids and benzodiazepines and Ritalin and Adderall and methamphetamine are just different ways of releasing dopamine. So be careful, because it's not uncommon for a patient to go from a heavy drinking phase in their life to an opioid phase or a stimulant phase. So keep that in mind when you're prescribing opioids, because if a patient is a cigarette smoker, by definition, they have the disease of addiction. By definition, they have the disease of dopamine resistance, of chronic dysphoria that is substance induced, and is an easy hop from nicotine addiction to an opioid addiction. Only about 14% of American adults smoke cigarettes today, but about 80% of people who go to rehab smoke cigarettes. There is a cause and effect relationship, we believe. Next slide. So what is the proof of this? And I'm going to go through one experiment, and I'm running short on time, so I'm going to go through this quickly. But this is one experiment done in Strasbourg, France. There are many out there, but this is just one. This is the assessment of morphine-induced hyperalgesia, hypersensitivity to pain, and analgesic tolerance in mice using thermal and mechanical nociceptive modalities. So what does that mean? Researchers took mice, lab mice, and they tested their pain tolerance. They did it two ways. They took the little mouse and they stuck his tail down in a vat of hot water, and they measured the amount of time in terms of seconds that the little mouse could leave their tail in the hot water before they became agitated and began to squeal. It's called a squeal test, and that's a measure of pain perception. The temperature was about 45 degrees centigrade, hot enough to hurt, but not hot enough to destroy the rat's tail. So they recorded the amount of time in seconds that the little mouse could leave their tail in the hot water before they begin to squeal and struggle. The second way is they created a little device, a vice, if you will, that slowly put pressure, clamped down pressure on the tail of the mouse, and recorded the amount of tail pressure on the mouse's tail that the little mouse could take before they begin to squeal and become agitated again. Again, a squeal test. And then they randomized the mice into two groups. One mice got a shot of morphine every day. The other group of mice got a shot of placebo, normal saline, salt water. The researchers did not know which mice were getting what, and I guess the mice didn't know. They were blind mice. So in a double-blinded test, with one group of mice randomly selected getting morphine and the other group randomly selected getting placebo, this is what they saw. Next slide. Next slide. Thank you. So pain tolerance in the minutes following the morphine injection at day 1, and then this is again on day 7. So they did it every day for 7 consecutive days, but this is the response to the pain following either the injection of morphine or the injection of saline. On the first day, the graph to the left, you notice that the morphine injected mice are able to leave their tails in the hot water a lot longer, 25 seconds, as compared to the mice who received the placebo. No big surprise there. Morphine treated mice can leave their tails in hot water longer than mice that don't have morphine. Morphine raises pain threshold, raises pain tolerance. No surprise there. But look what happens in the minutes following that stimulus. As the morphine begins to wear off, the mice who received a shot of morphine don't go back to the baseline and join the saline treated mice. They actually rebound below baseline and actually start squealing faster than the saline treated mice. So the stimulus is the A process and the rebound effect is the B process. They did this every day, and look at day 7. On day 7, the mice get a little bit of benefit from the morphine, the A process, but it doesn't last nearly as long, and the rebound effect becomes more and more painful. In fact, the morphine is making the mice hurt more in the long term. So, next slide. The next morning, the researchers, before they give the mice either their randomized morphine or their randomized placebo, measure the pain tolerance once the morphine is completely worn off the receptors. And this is what they see, that the morphine injected mice squeal a lot faster the morning after their morphine dose than the mice that received the saline dose. And over time, their pain tolerance gets worse over time. So their pain tolerance, their perception of what is a painful stimulus and what is not, is worsening over time. Next slide. Same thing is true with the tail pressure test. The mice begin to squeal with a lot less pressure in terms of grams of pressure on their tails, and each day of morphine use results in more pain experience of suffering of the mice once the morphine wears off. It's kind of the wussification, if you will, of the brain in the morphine treated mice. Next slide. So what's going on? Let me take you back to your neurophysiology and neuroanatomy days. This has to do with salience. Salience is the brain's perception of a quality of being particularly noticeable or importance. It's the order of prominence in our consciousness. It's priority of importance. So if you were to ask me, do I have shoes on my feet? Yep, I've got them on my feet. I don't have to look at them. I can feel them there, but I don't think about it all the time. It's not that important. It's very trivial to my perception. But now if you jab a nail in my foot, that has a higher order of salience. It has a more important prominence in my perception. So where is salience determined? Is it determined in my foot? No. Next slide. Salience is determined in the brain. So this is a pain pathway for salience. Consider a painful stimulus. It could be a bulging disc, it could be a toothache, it could be a nail sticking in my foot. But that stimulus is picked up through a peripheral nociceptive pain fiber, is carried through that peripheral pain pathway through a C fiber or another nociceptive fiber. It enters into my spinal cord through the dorsal root, passes through this very important dorsal root ganglion, crosses over to the contralateral spinothalamic tract, and then ascends up the spinothalamic tract through the rostroventromedulla and through the periectoductal gray matter. And as it passes through this region in the hypothalamus, salience is added. consciousness of the stimulus is added. The brain will say, hey, this is not important. It's shoes on your feet. You see this every day, so don't even think about it. It's not a big deal. Or this is really important. A nail sticking in your foot, that's not good for your survival. So that area in the rostroventral medulla and the periaqueductal gray matter is chock full of mu opioid receptors. And if a stimulus makes it through this area repetitively over and over and over again, the thalamus or the hypothalamus will actually adapt to that stimulus. So for instance, an analogy that I use is if I were to walk barefooted on rocks right now with my feet, that would be a very painful situation. But if I did it every day over and over and over again, then I would adapt to that and I would become accustomed to it and it would not be painful. It would have a lower order of salience. People say, well, they have calluses on their feet. Well, that's true, but there's more going on here than just calluses. The brain will adapt to a stimulus and say, in effect, hey, we've seen these rocks on his feet before. It's not caused him to lose his feet yet. So obviously it's not as big a threat as we originally thought. So we're going to close the loop on this pain threshold. We're going to lower the salience of it. And there's several processes by which this happens, but one is there is a descending anti-nociceptive pain pathway called the spinal bulbar tract that will descend back down my spinal cord and drop beta endorphin and enkephalins into my dorsal root ganglion, creating a balance and closing the gate to that stimulus coming through my spinal cord. And there are other anti-nociceptive adaptations that occur to make me tougher, to make my feet tougher, and to make me more tolerant of what I previously perceived as pain. This is a natural pain relieving process. And if we use opioids, in many ways, we don't adapt this anti-nociceptive process. Keep in mind that tolerance to synthetic opioids also creates tolerance to beta endorphins and other natural opioid that our body uses for pain control. So tolerance occurs at the rostroventral medulla and the periaqueductal gray. Tolerance occurs at the dorsal root ganglion, among other places. And so the natural beta endorphins and the enkephalins and so forth that our body uses are mitigated in their effects on their pain relief, and our pain tolerance lowers and lowers and lowers. Next slide. So let's look at some examples of opponent process theory. Alcohol and benzodiazepines, by the way, they are classically known as CNS depressants, central nervous system depressants. When we drink alcohol and take Xanax, we become lethargic. We have slow reaction times. We are somewhat sedated. We experience a sense of contentment and euphoria. That's the A process. That's the stimulus on our brains. But the brain will oppose that with the B process. The opposing process is anxiety, insomnia, agitation. And if we take benzodiazepines long enough or drink alcohol on a regular basis long enough, we will experience the ultimate central nervous system excitation event known as a grand mal seizure. And yes, all along our dysphoric effect of benzodiazepines and alcohol is increasing between our doses. Opioids are central nervous system depressants. They create some degree of sedation. There's respiratory depression in high enough doses. They cause GI constipation due to the stimulation of the mu receptors in the gut, decreasing gut motility. They create a sense of analgesia. They raise our pain tolerance, and they create a sense of euphoria. But the B process always follows the stimulus. So the B process is actually CNS excitation, insomnia, respiratory stimulation, and diarrhea. Have you ever seen someone in opioid withdrawals? They have diarrhea. It's the B process that is opposing the A process. And yes, they have hyperalgesia and dysphoria. Cocaine, similar situation, central nervous system excitation. Ellen, am I going to run over? Do I need to do something differently?
Yes, sir. We can give you about 5 more minutes.
Okay, all right, I'm going to get through this. So the problem is that cocaine has a similar type effect, and so on and so forth. Let's go to the next slide. So over time, we experience the situation where, do I take opioids because I'm in pain, or am I in pain because I take opioids? Do I take Xanax because I'm anxious, or am I anxious because I take Xanax? Do I drink vodka to help me sleep, or can I not sleep because I drink vodka? The answer to all these questions is yes, because of opponent process. Next slide. Here are some recommended books. I recommend Never Enough by Judith Greisel. This is an excellent science book. Chapter 3 is all about neuronal adaptation and the opponent process theory. Read it. Fentanyl Incorporated is a drug on the modern fentanyl trade in the United States and how this is going on. How to Change Your Mind is a book about psychedelics and how they may have therapeutic effects in addiction and other mental health disorders. Next slide. Questions?
All right. Does anybody have any questions? There's none. Well, I have one question actually. After a period of abstinence, does the brain return to its pre-addicted state?
In some ways, yes. So hedonic tone will always try to maintain a homeostatic balance. So if we can, lock a patient up in rehab, or we can go to a desert island where there are no dopamine releasing agents, the patient's hedonic tone will eventually come back to baseline. Circumstances still hurt. Post-traumatic stress disorder still creates chronic pain. Adverse childhood events still create a state of chronic pain. But the deal is that the hippocampus always stores up the emotional memory of pleasure, as it does the emotional memory of pain. And so that hippocampus has always got this craving that diminishes over time, but the cravings can be reactivated by triggers such as temptations, such as stress, such as other forms of pain. So yes, patients' homeostatic balance will return to normal if we quit dumping dopamine into our nucleus accumbens. However, the hippocampus has been changed for forever because of emotional memory, and those emotional memories will always create a risk for relapse and craving. Next.
All right. I just have one other question, and I think you've covered it already, but can people ever be cured of an SUD?
I don't want to think about people ever being cured of a substance use disorder. It can be driven into remission, and they can maintain long-term recovery for the rest of their lives, 40, 50 years. But still, every day they need to think of themselves as being at risk for relapse. And it's not just their drug of choice that they're at risk for relapsing. It could be heavy alcohol in one part of their life, and then they relapse to opioids, or it could be, some other form of dopamine releasing agent. At the end of the day, dope is dope. And that's true of marijuana. It's true of opioids. It's true of benzos. It's true of all. And so I think that we as providers have to be very, very careful and vigilant about that responsibility as we prescribe controlled substances that release dopamine. Just like a person with chronic kidney disease, we would want to avoid a non-steroidal anti-inflammatory drug that might cause an exacerbation of their kidney failure. We need to avoid, or at least show judicious respect for, controlled substances that release dopamine in people that are in recovery for addiction.
All right, well, that's all the questions I have for this one. I want to remind everyone that Dr. Boyette will be back on, let's see, I have the date here, August the 13th. He will do another presentation on buprenology. And so please come back to hear him. He's actually our next one. We're taking next weekend or next week off, and then he'll be back. Really quickly, just a little bit of information about your CEU, CMEs. You will get an evaluation sent to you on Monday from me, and please fill that out, answer the appropriate questions for your CE, CMEs. And I just wanted to let you know that those are sent at the end of every month to the appropriate group or agency. So for example, my providers, those are sent to MASA. They'll be sent on Monday for anything that you attended in July. And they'll be sent at the end of August for anything you attended in August. They've asked me to do it that way. This is the same for dentists as well. Now my pharmacist, they have requested I send for every webinar. So just wanted to give you that heads up. Social workers, you will get at the end of every webinar as well. So it just really depends on your group that you're getting the CEs from. So please join us for some upcoming webinars. We have some great ones. I do want to make one note. The one on August 27th, it says 2 to 5. However, it is broken down into parts. So there will be part 1, which will technically be an hour. So if you don't have the full 3 hours, then you can log on for, 2 to 3, 3 to 4, or 4 to 5. But I'll put that in an email to everybody who's been attending. So thank you, Dr. Boyette. We sure appreciate it. And thank you all for joining us, and hopefully we'll see you next time. Bye.
Thank you.